Bismillah ar-Rahman ar-Rahim. My presentation today is about echocardiography in the emergency room. This is a very important topic, and we are talking about the form of emergency echocardiography. It had some guidelines, and this one of them was the recommendation of the European Association of Cardiovascular Imaging. Of course, it's an important non-invasive tool, and it's able to do the echo in the ER. I will just start my presentation by who and how. Actually, who and how? Is it independent, or is it expert, or is it full, or is it focused? Is it goal-directed? It is resuscitative. Is it diagnostic? Is it symptom or sign-based? Is it procedure guidance? Is it therapeutic and monitoring? It has a very important role to play in patients presenting with first chest pain syndrome, hypotension, unexplained dyspnea, palpitation, recurrent syncope, possible etiology of embolus in patients with cerebral or peripheral embolism, just trauma. It has also an important role in aspiration of the pericardial fluid, as well as insertion of pacemaker. Primary indications: the thoracoabdominal trauma, the pulseless electric activity, the unexplained hypotension, the suspicion of pericardial effusion, tamponade. The secondary indication, it could be acute cardiac ischemia, pericardiocentesis. You can just, very important to help to get the fluid from the pericardium. External pacer capture, transverse venous pacer placement. Main clinical questions. What is the overall cardiac wall motion? You are just getting an important data about the wall motion. If there is a pericardial effusion, this is main clinical questions, which is very important. Of course, we have different probes: the small rounded footprint for the scan, the 2.5, 3.5, or 5. We have main cardiac views like the parasternal, the subcostal, the apical. You can look for the wall motion. Just look for the wall motion. Is it normal? Is it hyperkinetic? Is it over than the normal? Is it akinetic? There is no movement at all? Is it dyskinesia? It is failure to contract, bulges outward at systole. Hypokinetic, this is less than normal. The subcostal view, very important, because it's the most practical trauma setting, of course, because if your patient having some airway and neck trauma, you maybe have using the subcostal view will be very important. The subcostal view, you can see this is alternative also liver as acoustic window, and it's alternative to apical for chamber view. This is how you put the probe, and how, as we can see in the presentation, very important. The parasternal view, this is the next best imaging, and it's good for imaging the left ventricle. You can just compare, as we know that the right ventricle is always less than the left ventricle, and this is very important. When you find that the right ventricle is enlarged, this is very important. Maybe there is something important information you're going to get from the echocardiogram. If you have localized effusions, you can just, of course, you can differentiate between different levels. Is it pericardial or pleural effusion? What about this? Is how you put the probe for the parasternal long axis view, and this is how the beam goes and look for the heart for the parasternal view. The parasternal view, as we can see, look here. You can just find this is the mitral valve, and this is the interventricular septum, and this is how you can look for the heart. What about the parasternal short axis view? As you can see, this is how the patient is placed, and this is the left ventricle, and this is the right ventricle, and it's just, as we all say, that the right ventricle is usually a complex structure, and it looks like a crescent shape, and that's why this is the right ventricle, as we can see, and this is the right ventricle. Actually, this gives an idea of how everything is different. I'll tell you something. This is the right ventricle, and this is the left ventricle. Usually it's circular in shape, but the right ventricle is crescent in shape. It's a very, it has, you know, a very complex geometry, and that's why you are not able always to get the function of the right ventricle. This is the short axis view. As we can see, this is the aortic valve, this is the RVOT, and this is the left atrium, and this is the right atrium. You can get very important data from these structures. You are looking here for the how it looks. They are surrounding the the aorta, and this is how like the aortic valve looks like a Mercedes sign, and you can see it's very important. You can diagnose here the bicuspid aortic valve, the quadricuspid aortic valve, and many abnormalities. Difficult view. This is the apical view. It's difficult view to obtain. It allows comparison of the ventricular chamber size as a good window to assess septal wall motion abnormality. This is the apical four-chamber view. You can see how this is the apex, and this is actually, you can see the two chambers we have, and this is how you can look to get this very important apical view. But actually, and this is the apical two-chamber view, the patient should be in the left lateral decubitus. You just should be lying in the lateral decubitus, and you can look look for the. This is how you look for the apical chamber. It looks very good at the inferior anterior walls. I have stated a lot about the views, but actually the ER, you should have a goal, and you have to do a focused examination looking for what you are looking for. Is it guided? You are looking for the effusion, you are looking for the wall motion abnormality, you are looking for the global function of the heart, you are looking for something emergency like for example VSR or ventral septal defects due to post-MI. What are you looking for? This is very important. Also, you can do the pericardiocentesis, subcostal view. You can look for this is the traditional approach, and it's blind usually. But there is increased risk of injury to liver and the heart. It's echo-guided. This is true, but you can, if you use the echo-guided, it's better that you can use the left parasternal for needle entry. Actually, this place you are able, it is not blind. You can able to detect through the echo how to get what you want from the pericardiocentesis. As well, it has a very important item that it has the largest area of fluid collection adjacent to the chest wall. This is the pericardiocentesis technique. Also, we do encounter many patients in the ER with penetrating cardiac trauma. However, the echocardiographic signs of rising intra-pericardial pressure, you can see collapse of the right ventricle free wall. You can see dilated inferior vena cava and hepatic veins. You can detect pericardial effusion. It can develop very suddenly. It may even exist before the clinical signs develop. So we have to state very important that it can exist even before clinical signs. And it's very important because if you detect the early, it is if you can detect this penetrating trauma before the hypotension develops, this will be amazing. You will have amazing result. So echo in this way is very important because it can detect the early detection of pericardial effusion, as well as can detect the signs of rising intra-pericardial pressure. I'll say something very important. This is the core slide of our presentation today because it tells it's very important in a case of penetrating trauma. What about focused cardiac ultrasound? This is a very important, focused ultrasound. You have goal or focused cardiac. What does that mean? You are going to do an echocardiogram for a patient for a definite goal. You're not just doing a full study. You are not doing actually a detailed study, a conventional study. No, it is just goal directed. Why? You look for the effusion, you look for the function, you look for the enlargement, you look for the intravascular volume assessment. You can guide for pericardiocentesis. You can confirm pacing wire placement. So these are mainly the indications of focused cardiac ultrasound. Summary. What about bedside echo? But bedside echo can help to assess overall cardiac function, motion, identify clinical significant effusion, useful in the assessment of the patient with unexplained hypertension.